maybe we should close by talking about a couple of the brand new agents, which I don't know that much about. Maybe you know more, but my understanding is the last time I looked, there were 5 drugs directly targeting KRAS mutations, predominantly G12C. There are a lot of so-called modulators that we're looking at in clinical trial, like SHEP2 inhibitors and so forth. But what about the other ones that are direct inhibitors? The data are good preclinically.
Yeah.
Less in the clinic is known.
I agree. I think I didn't even know there were 5. So I've learned something. I know of 2 more, that a J&J drug and another license plate therapy that, like you said, have performed quite well preclinically. I think the question will be, are there real meaningful differences when we put these drugs into clinic? And do we need this many drugs, or do we need to look at how to combine these drugs with other agents that elicit meaningful responses? And it's interesting. I don't know where this will all, if it mirrors the other, genotype-directed therapies, hopefully these drugs will land as first line, and then we can build upon that with adding drugs or looking at drugs and resistance. Maybe it is like we have learned in EGFR, some of these drugs that are coming down, we combine with chemotherapy and improve outcomes that way, or immunotherapy. But we have a lot of drugs that have come down. I think we've got to expand beyond KRAS G12C. I think we need to tackle the other subtypes if possible and come up with some combination strategies that are rooted in scientific rationale. But I don't know of any differences between these new agents that are coming out in terms of their preclinical efficacy, or whether they will make any difference compared to one another when it gets to the clinic.
Well, luckily there is a lot of research being done. 2 days ago at AACR, the KRAS Dream Team presented on non-small cell lung cancer, the preclinical data in particular, quite intriguing. Of course, I can't tell you any of the results, otherwise we would have to kill you. You know that line. But at any rate, there is a lot going on, and hopefully it will lead to more understanding and even better use of these drugs or alternative strategies.
Yeah. Well, there's just been such extraordinary advances in the field, and I got into this field and always had learned KRAS is undruggable, we can't do it, and here we are now, and really at the forefront of some very exciting times, I think, for our patients in selecting therapies based on their genotype. Any final parting shots, David, before we wrap up here?
One of my favorite quotations is, "Not all mutations are created equal." So that's true for the KRAS mutations. And I guess lastly, that if we have said we've built up from 1 to 2 to 4 up to 8 oncogenes we need to test for up front, that pretty soon I think we will have number 9. Yeah. And that is to bring back KRAS, specifically looking for G12C.
Love it. Just starting to hit the tip of the iceberg, I think. Very exciting time. So this has been extremely informative. Thank you, Dr. Gandera, for this insightful discussion. Thank you to our audience for watching this Target Oncology presentation on precision medicine. We hope you found this discussion to be useful and informative.